Hearing, smell, and taste. 3 out of the 5 senses aren't bad. Our ears, nose, and throat. Tonight, On Call with the Prairie Doc. Good evening, and welcome to On Call with the Prairie Doc. Our ears, nose, and throat are important interfaces between us and our surroundings. What we hear, smell, taste, or breathe in and out all move through one of these passages. First, let's take a look at this week's Prairie Doc quiz question. It is true or false question tonight, true or false. 1 in every 3 people over the age of 65, a total of 165 million people worldwide, lives with hearing loss. True or false? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. But we answer your questions through the night about ears, nose, and throat as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight is Dr. Jonathan Mellema of the Avera Medical Group Specialty Care, Brookings. Welcome, Jonathan.
Thanks for having me.
So you and I had a chance to get to meet each other on the radio a couple months ago, and I said, good guy, he's going to be perfect for the TV, and we'll have a chance to interact one more time.
I passed my first test.
Yes, you did. And so we're talking about ears, nose, and throat problems, and of course the general topic I kind of wanted to make sure that we covered, but we would take all questions about any ears, nose, and throat issues. But let's talk about hearing. Hearing loss is more devastating than we think, isn't it? Mm-hmm. Tell me that.
Yeah, hearing loss is definitely underreported. There's the numbers that you were quoting there at the beginning. It may be even higher. The problem is that frequently people don't recognize the signs of it, or it's so slow in onset that people don't notice it themselves.
Or they deny it, even though they know they've got it.
Yeah, it's very common to see somebody in the office with their spouse, and their spouse is saying they have hearing loss, and they're saying, "No, I don't. You just mumble."
Yeah.
So
it's that you can't hear your wife. She's got to speak up more. That's the problem.
That's what they frequently say. Yes.
And it's guys. Guys are more often deaf or have lost hearing than women. Because of why would that be?
Well, there are some genetic factors, but in addition to that, men are more commonly in traditional jobs have had noise exposure through their life. So noise is a critical component of hearing loss. But other things that are very commonly associated with things like heart disease are also going to put you at risk of hearing loss. Hypertension.
That's blood flow to the ear area.
Just like any other organ that's at the kind of end of the vascular tree where it's getting the very, very small vessels, is going to be more vulnerable to those kind of issues.
So, and what other causes? I mean, you were about to tell us that, and I interrupted you. I'm sorry.
Well, there's definitely genetic. There's also what we call ototoxins, which are medications or other substances that can make you more prone to losing your hearing.
Gentamicin was the big one. I mean, I poured a ton of gentamicin into people, saved their lives with an antibiotic, but then they had some hearing loss afterwards.
Yep. Very common cause of it, and actually is used somewhat therapeutically in some instances to try and actually cause some injury to the ear if there's too much vertigo and certain disease processes.
Oh, really? I've not heard that.
For some people who have severe Meniere's disease or some other things that can cause major issues with vertigo or balance, occasionally gets used. In those situations, usually it gets dripped through like an ear tube, or you inject it actually through the eardrum into the middle ear. But other problems, diabetes is definitely going to increase your risk of hearing loss, as is smoke exposure.
And that's vascular, isn't it?
Yep.
I mean, the blood flows are
Yep.
reduced in their case.
And in diabetes as well, probably some of the neuropathy issues, that maybe that could play a role as well. But definitely it's the blood flow. It makes a big difference.
I will add chemotherapy to your list.
Yes, yep, chemotherapy, certain water pills, hydrocodone, as people who've had addictions to opiates can have some significant hearing loss from that. And
is that permanent with the hydrocodone?
It can be, yeah. There's a very well-known radio host that ended up with bilateral cochlear implants because of his struggles with Vicodin addiction.
Yeah.
Mm-hmm. Yeah.
So there's a lot of causes for hearing loss.
Oh yeah.
I think though it's mostly the buzzsaw and no ear protectors.
Yeah, just like anything else, when you're younger, you feel like you're indestructible. So a lot of times, this whole idea of I can be around loud music all the time, I can run the chainsaw, and those things do add up over time. The problem with hearing loss is frequently when it's gone, it's gone. It's not often that you can recover it.
Yeah. Now, I mean, people who have ringing in their ears. Mm-hmm. Oftentimes that's a sign that they have hearing loss, isn't it?
Yeah, a lot of times that's what gets people in the door more so than believing other people saying they don't hear well. It's hearing a tinnitus is the term.
Not tinnitus.
Right.
Tinnitus.
Yes, because there's a US, not an IS. It's not an inflammation. But
right.
Any noise that's in the ear that's not supposed to be in the ear is considered tinnitus. And in general, most tinnitus is going to be perceived as kind of a constant noise. It may be high-pitched, low-pitched. There's a lot of variety. But some people hear the ocean. Some people hear crickets. In general, most tinnitus is a reflection of hearing loss. Now, there are some more unusual types of tinnitus, like pulsatile, where you're actually hearing your heartbeat in your ear. Those are more concerning about other problems, vascular problems, tumors, things like that. But
right.
The majority of tinnitus is going to be a constant when it's there. Might fluctuate, come and go, but it's not going with your heartbeat.
The tinnitus that I have of late will hit me suddenly. I'll go right there, and if I just ignore it, it goes away. Mm-hmm. Or my body adjusts to it, or I get used to it, or something. Mm-hmm. But I'll have those episodes where it just hits. Boom, there it is. Mm-hmm. I don't think that's unusual, is it?
No, those short-lived tinnitus moments that seem to completely resolve usually don't signify anything really major going on. If it's becoming more prolonged, more constant, then you probably need to be a little bit more concerned about it. But they actually had I'm going to misquote this study, but they actually had a study where they took adults and they put them kind of in a sensory deprivation kind of situation from an audiologic standpoint. So, and about, I believe it was 7% would report that they heard noise in the ear at that time. And over the lifetime of any individual, roughly about 40% will have tinnitus for some period of time in their life.
So a lot of people come in for tinnitus. They came to me as an internist for tinnitus, and they come to you. What do you do for it?
The first thing is always to get a hearing test, because you want to know, does he or she actually have hearing loss, and what kind of hearing loss. You also obviously get a good exam. You want to have a good history and look and see if there's any medications that they may have been on. One of the more common ototoxic medications is a loop diuretic like Lasix or furosemide that can cause hearing loss and vertigo or tinnitus. Yeah. And a lot of people are on that for swelling or heart failure and things like that.
I prescribed a ton of furosemide.
Yeah.
Is Demodex any better than?
That's a good question. I'm not sure.
Demodex is like furosemide or Lasix.
Yeah, those. I think, as far as I recall, all the loop diuretics have a risk of hearing loss. It's hard though, because a lot of people get put on loop diuretics, have a lot of other risk factors for hearing loss as well. So the association and causation, but there seems to be a causation with loop diuretics to a certain extent.
So if a person comes in with tinnitus and you've tested them and done all your tests and you really don't have a solution for them, what is your common treatment for tinnitus?
I think, a lot of people need some counseling to understand that they're not alone. This is a very common problem. And unfortunately, we don't have a great answer for why did it start now. The hearing loss may have been there for 10 years, and now I've got tinnitus, and I didn't before. So kind of going through that with them, that this is not a rare thing. We do know there are some things that tend to aggravate tinnitus in a lot of people. One would be just stress, whether it be psychological, physiologic. Any stress can make tinnitus worse. We also see some aggravation for people with caffeine, with the coffee, aspirin sometimes, or aspirin-like products. trying to counsel them on other things that we know are going to put them at risk down the road of making this worse, like smoking cessation and good diabetic management, trying to keep their hypertension under control, all these things that most people don't really think of as being kind of contributing to it.
My good friend, Dr. Reitz, the ears, nose, and throat guy who worked and practiced in Brookings for 1,000 years, I think, up until just recently, used to tell people, there's not much we can do about it, just turn the radio on and then change the channel to a point where you just have the little white sound in the background.
The vast majority of patients can manage their tinnitus, and usually it's more noticeable in general in a quiet room. So yes, having some sort of background noise is really common advice to go with, and that could be anything from the fancy white noise generators to just a fan, and everybody kind of experiments around and figures out what works better for them.
You've got wave machines that have the beaches coming in and so on and so forth. What do you think of them?
I think that they can be very useful for the right people, and I usually advise people to try something inexpensive first instead of going out and buying something new. Try your humidifier, or try your fan or something.
Your fan, just having a fan in the corner.
Yep.
We're getting some good calls, and I just love it. A caller from Spearfish comments that she lost her sense of taste after having whooping cough. Have you heard of this before? Are there other illnesses that affect your sense of taste? Taste is a really interesting one.
Taste is very interesting. The majority of what we consider taste is actually your sense of smell. And I don't know how they quantify it, but they always would tell you 90% of taste is smell.
Yes.
Majority of what is truly taste is usually more like the sweet, sour, salty, bitter, to kind of get those things. But to get the real nuances and be able to tell this is strawberry or this is grape, that's your sense of smell. And we do know typically that when people come in complaining of taste, it's almost I would say at least 90%, if not higher, that it's a sense of smell issue. Unfortunately, that's kind of an area that doesn't have a lot of big dollars invested in it because it's not life-threatening. But we do have some things that are been associated with some better recovery of your sense of taste or smell. Usually when you look at sense of taste, or if it is from a smell, truly from a smell deficit, you're looking, is there an obstruction? Do you have polyps in your nose, which you often can't see unless you look up with an endoscope. Chronic infection, allergies, things of that nature, things that are going to cause congestion and swelling or blockage. You want to know, has there been any head trauma? Whiplash injuries or head trauma can cause the olfactory nerve to shear right off of the what's called a cribriform plate, which is this little perforated piece of bone where all these little neurons come through, and that can just tear right off, and then you lost your sense of smell. And the post-viral, this would be falling more into that sort of situation, post-infectious. We don't completely understand it, but it's somehow, it may be the actual bacteria or virus causing the damage, and it may be the immune response to it. But yeah, it's one of the top 3 causes of loss of smell or loss of taste.
I had one guy come in with a loss of taste, and I kind of went through his history. And it was about the same time that he lost his taste was the time that he started taking this zinc cold medicine. So I said,
nasal spray?
Well, no, it was the zinc. It was the oral
Zicam.
zinc.
It was oral, okay.
It was an oral Zicam, or it was an oral zinc. And stopped the zinc, and everything came back.
It's interesting. Topical zinc is a neurotoxin, so there is a spray out there called Zicam. There's an oral version too, but the topical version is known to cause loss of smell.
Yeah.
And that can be permanent too from the topical. Yeah.
Heavy metal exposure too. So it's, you got to say to your doctor, maybe I should be tested for lead and for heavy metal things, and I'm not taking zinc anymore, and so on and so forth. So that's it.
As far as recovery of your sense of smell, though, if it's an initial, early on injury, it might have some benefit from a steroid course, but that's not real reliable. Some of these neurologic injuries can have some benefit from things like hyperbaric oxygen traditionally, but these are not widely available, and there's a lot of issues of trying to actually get that taken care of. But now there's a few studies that have shown some positive effects from nasal saline flushes with steroids in them, budesonide.
Oh yeah.
So it actually gets all the way up there, because nasal sprays don't usually get beyond the kind of roof of the outer part of the nose, not up to where the olfactory cleft is. Fatty acids, fish oil basically. And then the other thing is what they call olfactory retraining, where you usually have, the study looked at 4 separate different smells. And I don't know why they chose the ones they chose, but the study had clove, rose, lemon, and eucalyptus. And they recommended, they had their patients present that and sniff it, smell it basically for 15 seconds each one, twice a day for 4 months. And the longer they did it, the better recovery they had.
Really?
Yeah. Unfortunately, it wasn't 100% recovery, but it was more functional. And one of the problems when you lose your sense of taste and smell is you lose the pleasures of enjoying eating, and a lot of people lose weight and have, which I maybe need to lose my sense of smell. So
Yeah, that's a tough one. And I mean, you know, by the way, Z-Pak, which is an antibiotic, doesn't have zinc in it.
No.
So that's one of them. Caller from Lenox states that she took tamoxifen and as a result had ototoxic hearing loss. She would like you to elaborate on that. Have you heard about the tamoxifen causing problems?
You know, I wasn't aware of the specific statistics on tamoxifen. And when you look at the inserts on a lot of different medications, tinnitus and hearing loss are listed in a lot of things, and the actual association, what percentage and how severe, is not well delineated. Right. I personally don't know about tamoxifen well enough to make a big global statement about it, but typically with most of the ototoxic medications, cessation doesn't bring the hearing back, unfortunately. Tinnitus is a little different, whereas if it's being aggravated by caffeine or by aspirin, if you stop it, the tinnitus often does improve, but unfortunately not with hearing loss.
Like most everything in healthcare, the earlier you begin to treat the problem, the better the outcome may be. Hearing loss is just as important to address as soon as you notice it.
Audiology, it's a profession of evaluating and treating hearing loss, balance disorders, tinnitus and ringing of the ear. We work with anywhere from the newborns all the way to the geriatric age. A lot of our practice is really based on hearing aid dispensing and really improving people's quality of life through better hearing through hearing aids. Our first responsibility for our patients is a medical exam, and so when people come to see us, usually something has happened to trigger why they've come in. It could be a sudden hearing loss. People are just beginning to notice that they have difficulty hearing, understanding speech. Oftentimes, unfortunately, it takes somebody 7 years to come and see us. 7 years prior, they have found out they feel that they have a hearing issue, but it takes them 7 years to finally come into our doors. So we're trying to improve that if we can. But when somebody does walk into our office, we do a thorough case history. It's a medical case history. We look into their ear canals to make sure it's not an earwax issue, make sure the eardrums are functioning and there's no holes in them and such. And then we bring them into our soundproof booth and we have a thorough exam where we actually are looking at giving them beeps in their ears and allowing them, or helping us see where they hear and how they hear in certain pitch levels. The majority of hearing loss is due to age-related. As we age, our little tiny hair cells that we have inside of our ear, our hearing nerve, they deplete about 0.5% per year of our life. So by the time we hit a certain age, especially over 60, you're going to begin to have some type of a hearing loss. When people get their hearing aids, you cannot just let people go out into the world with hearing aids by themselves, just with the volume. The brain has to do a lot of changing. And so we spend a lot of time counseling our patients regarding what expectations they have when you have that first volume coming back. If remember, these patients may have not heard for 20 years. And so that system is not used to all this sound coming in. And so we have to counsel a patient, explain that your neural pathway, the hearing pathway in your brain has to form again. So the more severe, the different type of product we have to do. You may see people that have like an ear mole, like a piece of plastic in their ear, then the tubing comes up and then the hearing aid sits behind their ear. That is more for power, for people who need power, who have a more severe hearing loss. If somebody has more of a mild hearing loss or moderate hearing loss, then we can do the really thin tube ones, the really thin tube that come up and sit behind the ear that way. Those are then more effective. If they have normal hearing in low pitches, they can still hear that hearing without plugging their ears up, but we're giving them back the high pitches they need from that device. If it is a hearing aid or other kind of assisted listening device, then we will walk hand in hand with them as well in that process to make sure that that's a positive experience.
This is your program, and your questions are key to the direction of our discussion, and we're getting good questions. Call in your questions to 1-888-376-6225 or send us an email to ask@prairiedoc.org. John, earlier you had, in a private discussion, we talked about isolation and the problems that occur in hearing loss in older people. Can you comment about that?
Sure. In days past, it was just kind of thought it'd be a nuisance, but and not be so much of a global health problem. But now they're showing significant evidence that not only can it cause social isolation and depression, that gets misdiagnosed sometimes as a psychiatric disorder, and it turns out they just can't hear. It also seems to correlate with the risk of dementia and things like Parkinson's and Alzheimer's. So if you amplify people who have hearing loss,
give them a hearing aid,
and you compare those to people who have hearing loss and don't get a hearing aid, they show an increased risk of more advanced dementia in people who don't amplify. So hearing aids not only have a benefit for social issues, it may help stave off some dementia progression. So,
right.
Yeah.
Okay. Let's dive into some questions, and we've got some good questions.
Oh, I hope I can answer them.
A caller from Lenox states that she took, I have Barrett's esophagus and had the TIF procedure done a few months ago. My chronic cough has decreased, but I still seem to choke on foods often, mostly nuts, morning cereal. Any suggestions?
Barrett's esophagus is typically a precancerous condition in the esophagus caused by excessive acid exposure, usually close to the origin
of the stomach, not lower than a higher.
Yeah, but they do have. There is kind of a reflex where if your esophagus is irritated, it can create more phlegm. It can create more kind of that sensation of mucus or a lump in the throat sensation, and we're not good at correlating where exactly that is, but. You do see that when you look down at people's throats that have had a lot of reflux, that some of the muscles kind of hypertrophy. It's almost like they're kind of squeezing to keep things down.
Yeah.
And the result is that has to relax in order for you to swallow. So the more firm things to go down have to have more relaxation. And if the esophagus is always tight, sometimes it's psychologically you feel it more, but also it may mechanically be more difficult to pass it. So usually you see it,
those.
If it's a stricture, yeah, dilate it. Sometimes it's going to be more about having not only your reflux under control, but having to make some dietary modifications of not only for the reflux, but also chewing things better, giving up on some of the more dry foods or thicker things to swallow,
right.
And let it heal. It takes a long time, and sometimes it never gets back to normal. So.
A caller from Brookings asks about the cause of stuck stapes bone. So explain the bones of the middle ear. I mean, the outer ear is the tube, and there's the eardrum. The inner ear is the nerves that receive the message and carry it to the brain, but there's this middle ear.
Yes. So there's three bones in the middle ear. Yep. The malleus, the incus, and the stapes. The stapes is the third bone, and that is the one that actually is vibrating in and out of the inner ear, and it's kind of like being on a little trampoline. That has to be flexible so that the vibrations from the eardrum can be carried to the inner ear. Anything that stiffens that chain can cause what's called conductive hearing loss, which is usually the type of hearing loss we can surgically improve for the most part. But the stapes, in the situations of something called otosclerosis, the bone where there's supposed to be kind of a membrane to bounce becomes ossified or bone, and therefore they can't move. Right.
And there's a surgery you can do.
There is a surgery you can do that you can remove the stapes bone and replace it with usually a titanium. There's a lot of different prostheses on the market, but if everything goes well, you can have usually get all the conductive hearing loss back.
That's a wonderful thing. Mm-hmm. And conductive is one of those things that's helped by the hearing aid more than the neurologic loss.
In general, it doesn't require the processing. The higher processing functions aren't as affected by that. So if you get it loud enough to get to the nerve, then you can still understand a lot better.
A male caller from Irene asks if I had an obstructed septum. Is it a danger to have an operation at the age of 72 with fear of infection? So people talk about sinus surgery and septum infection and so on and so forth. Very quickly, I sense that there's too much sinus surgery going on that is profitable for people, and maybe we could do a little bit more careful selection in those cases.
I think just like any profession or any specialty, there's people who are making a good effort of trying to pick the patients that really should have surgery and try to help people understand that if surgery won't help them or won't be of much benefit. Sinus surgery can be easy to abuse if you wanted to, because people get told all their life that their headaches from a sinus problem, or that their drippy nose it means that they have a sinus problem, and that if you have surgery that will be fixed. There is a placebo effect as well to surgery, just like there is with medication. So some people will have surgery and feel like their headaches go away, and it might be from the sinus surgery, but it also might not be. So it can be a tough thing to sometimes really differentiate who would benefit from this.
Yes.
People who have really severely affected sinuses, that's an easy call.
I mean, there's a time for surgery.
Oh, there's people who you look at the CAT scan and you say, this is definitely something that needs surgery.
We need to drain this.
Yeah, but I've done sinus surgery. I think the oldest person I've done sinus surgery on is 85.
It's not an age issue.
No, you can do it at any age. You may have higher operative risk if you're older and you have other comorbidities, of course. But yeah, septoplasty in a 72-year-old is not a thing I blink at.
Okay. A male caller from Sioux Falls states, I have a situation where at night or when I am laying down, the mucus from my nose and the back of my throat that goes through my eustachian tube makes my ears itch and tickle and drips a liquid. I'm wondering what may be the cause. Now that's interesting.
I hear people come in and complain that they feel this drainage in the back of their throat that they perceive is coming from their eustachian tube, and they usually indicate, well, I feel like kind of like coming from my ear this way. Our brain is very bad at figuring out where mucus is actually coming from, despite it may feel very much like that, but that's very unlikely to really be able to differentiate it. There are some people who have chronic drainage, don't get me wrong, but the vast majority of those patients, that is not coming from the ear. I think the question I'd want to know is the drainage that they're feeling, are they seeing this on their pillow? Is this coming out of their ear, or is this something that they just have the sensation in the throat?
Yeah.
A lot of these things that have some chronic low-grade irritation, like a dry ear canal, like dermatitis, like almost an eczema in your ear, it's going to be unmasked more when you have no other sensory input to distract you. So you're laying in bed, you're trying to fall asleep, and then you just feel that itchiness. Also, if your ear is occluded, sometimes you get some moisture that may build up, and that might be a little more on the itchy side of things, but it could just be normal sweat. So it's going to be important to get the ear looked at to see, is there a perforation, or is this just a normal healthy eardrum and maybe a slightly irritated ear canal?
Yeah, it's a complicated story here, isn't it?
It is. It takes quite a bit to figure it out, even though it sounds like a very minor problem. It's very bothersome though too.
Yeah. I've had very bad thrush 3 times in my mouth and throat, have taken meds and mouthwash. Now my tongue looks like it has cuts on it and is sore. What else can I do? Change foods? Take supplements?
Well, it's going to come down to where are we getting this thrush from? People who get thrush commonly, as you know, like inhaled steroids, if they're not getting it rinsed out well enough, that causes fungal overgrowth in the mouth, and that can be a real problematic thing. People who are immune suppressed, diabetics sometimes.
Chemotherapy patients.
Sure. And thrush usually is something that's pretty easily treated, but there are times where it just keeps coming back and can be very frustrating. So looking at oral hygiene is a big one. And when you've developed that kind of irritation of the tongue, is it because of the recurrent thrush or the medications? So and nutrition is important as well.
So that's a complicated story as well.
It is.
You're in a complicated field. There's no question about it. It's not easy.
Yeah. There's oftentimes you have to kind of trial and error to try and see if you can figure out what might be more causative for a patient.
A woman from Edgemont asks, is there anything that can be done about a runny nose? My nose runs without warning, especially when I'm eating and when I look down. Then when I try to blow, there's nothing there.
The runny nose is, again, something that becomes more common as we get older. The nerves that control the secretory function of the nose, what we would term as mucus coming out, don't function as well as we get older. And one of the classic things with something called vasomotor rhinitis, which is this dysregulation of the mucus in the nose.
Which is exactly what she has.
Yeah, that's very commonly with certain smells like chemicals, perfumes, tobacco, but also very common with food around eating time. And there's a spray called ipratropium that is much more effective for that you can take 3 times a day instead of like a nasal steroid or a saline spray, and that can help shut that down. But there's now a medical procedure too that is new, and we get a little cryotherapy probe back into the nose near where the ganglion is for that nerve, and freeze it. And they've looked at that for people who are having chronic postnasal drip with cough, and it's about 80% effective at getting rid of that. It takes a couple months to heal. It doesn't really hurt, but it takes a couple months to see the results.
All right, wow. A Rapid City caller asks, why hearing aids why are they so expensive?
Well,
the technology of it all?
There's definitely the research development, that kind of stuff that people like to throw out there, and the technology, the micro circuit boards and all that kind of stuff. So there is a cost to that. You also have to be able to, the people selling them have to be able to keep their doors open. But you also have to be careful, just like anything else. The people back in the day, the used car salesmen got the bad rap for putting the price up too high, and there are people who charge more than they should for it. So I wouldn't be afraid to get a second opinion. Most hearing aid dealers will give you a free consultation, hoping to sell you a hearing aid. Yeah. But if you're getting quoted numbers that are $5,000 for one hearing aid, then you might be getting a raw deal.
Look at price at Costco, for example, in Sioux Falls. People talk about Costco being cheaper than everywhere else. They're about half price or something like that.
Some of that will be bulk due to bulk distributing.
Selling so much of it, yeah.
And some of it'll be the people who are selling the hearing aids. If that's their business, they have to sell a hearing aid to make to pay their bills. If they're hired by Costco, they're getting a guaranteed income the whole time. And so if Costco wants to eat the difference and say, okay, this will bring more people into our store, they'll buy a bunch of other stuff too.
It's a loss leader.
They might take a loss and do well there. But there recently was a law passed to allow hearing aids without over-the-counter hearing aid without an audiologist, and those are less expensive, but they're also going to be less individualized too. Yeah. So, but they can be a very good option for somebody who just can't afford the full price.
Where can you find those?
Some of the major carriers like Costco and Sam's Club and stuff are starting to carry them. I'm not sure how widely available they are yet.
Over-the-counter, non-prescribed. Wow. A digital revolution improved the hearing aid technology dramatically. There are no longer just amplifiers. They adjust to the hearing environment and the changes that take place.
There's a big difference between the hearing aids today, and I would say even probably up to 4 years ago. There's typically 4 levels of technology with most manufacturers, from a premium end down to an essential end. And what they do is they take away functions as far as hearing in crowded situations mostly. She had that mid-level hearing aid, and so when I fit loaners on my patients, they're always the premium products. And so I put that product on her, and even after I got her repair back, we couldn't fit it for a while because they were out of town or whatever the deal was. And when I put her old hearing aids back on her, she noticed a huge difference as far as hearing in competing noisy environments. Really, anything you can do on Bluetooth, you can do through your hearing aids. So hitting on the volume button, it'll accept a phone call or it can reject a phone call. And then that patient is actually hearing the phone conversation through both hearing aids, which is incredible. So they're hearing binaurally instead of monaurally. We got to remember that digital technology did not come around until 96, 97. Before that, we had programmable hearing aids. Before that, analog. And analog just amplified or you didn't. Digital technology is better than, say, the programmable or the analog. Is that hearing aid's thinking at over 1,000 times per second, trying to figure out what environment it's in. What's the signal to noise ratio? There's a difference between being in a car and trying to have a conversation versus you and I having a conversation in a quiet area. And so that digital hearing aid, which is thinking so quickly and trying to figure out the environment it's in, is giving the user the ability not to have to work so hard to hear. The hearing is coming more naturally to that patient where they're not fatigued at the end of the day. The statistic is that it takes a patient on average 7 to 10 years after a hearing loss has been identified to actually get hearing aids. The technology is there. It's going to improve your life. It's going to make you a much happier person. You're going to be more involved and active. So I see nothing but positives by at least giving it a try, especially if you've got a trial period in which you can use them. So why not?
So all this about hearing aid, it makes me think about, I just bought a used car and it doesn't have one bell or one whistle on it. And it's really remarkably less expensive than all of the others I was looking at with the same brand and everything even. So sometimes you don't even need a bell. You don't need that bell or that whistle. And if you get less because it works just what you need, you can get it for cheaper.
Yeah.
Was that an explanation that fits for you?
Yeah, that's definitely a good point. I mean, there's a lot of functionality that's been built into the hearing aids, and some of them Bluetooth to your phone. You can control them with your phone. Multiple different programming functions if you're going to be in a group or if you're trying to listen to something more straight ahead of you. So yeah, if you get the more functionality you get, the more expensive the hearing aid is going to be. And in general, I would say probably the Costco type hearing aids probably going to be less bells and whistles, but some people
Might be all they need.
That's what they need, yeah. And a good audiologist is going to go over those options with you, and they usually will also offer lower priced alternatives as well. So don't be afraid to say, hey, what is there something that's less expensive, and what would I have to give up to get the less expensive one?
There it is, a human being that advises you. Yeah. Is there anything proactive I can do to avoid a vertigo episode?
Vertigo is a very complex problem, and unfortunately not enough time to describe all the things with the
vertigo is the twirling. And
true
of course,
vertigo, yep.
As an internist, half of the vertigo is just lightheadedness. They stand up and they get lightheaded. That's not vertigo, and that's because I'm prescribing too many blood pressure pills, or they have a heart problem we don't know about, or something along that line. But vertigo is
a sensation of movement when you're not moving, for probably the most basic explanation for it. And there are multiple things that can go into vertigo, but one of the more common things is becoming more and more recognized as something called migraine-associated dizziness. And that, we're just like some weird migraines can cause you to have symptoms like a stroke for a temporary period of time, or troubles with your speech, or hemiparesis, or paralyzed half of your body. That can also happen even without a headache. And so more and more that's being recognized, and some of the same things that we use to control migraines can help with that.
And of course, to understand migraines is another show that goes hours.
Yeah, vertigo is a very complex thing.
About tinnitus. I have ringing in my ears all the time, and I just got hearing aids. Will this be there for the rest of my life, or is there anything I can do about it? You think the hearing aids had anything to do with the tinnitus?
No, not likely. The tinnitus, unfortunately, tinnitus is so random when it comes on. And, people can have hearing loss for years and then get tinnitus later. And it's like, why did it happen now? And we don't have an answer for that. Sometimes it might be coincident at the same time you got that hearing aid, but the actual hearing aid itself, the benefits of being able to hear outweigh whether you think that tinnitus might be a little more aggravated. But some hearing aids will come with a masking function to try and cancel the tinnitus. And in some people that's very effective, some people it's not. But masking is probably the most common thing people do, have some other competing sound.
So this is related to our last discussion about bells and whistles and so on and so forth. A caller from Sioux Falls asked, how do I select someone to visit for hearing aids, and what kind of hearing aid is best? So who is this guy or gal who's going to advise me to buy the right hearing aid?
That's a good question. If you've gone in and seen an ENT or an otolaryngologist.
Start at the ears, nose, and throat, or an otolaryngologist.
Frequently, they'll have somebody who they're associated with that they can recommend, that they feel comfortable recommending. There are a lot of hearing aid dealers out there, and there's a lot of really good hearing aid dealers. Unfortunately, we don't know everyone, and we can't. We'd like to have a great relationship with everybody, but if in doubt, I'd say don't be afraid to get a second opinion from a different audiologist, even if the first one was recommended to you by someone else.
All right. A caller from Brookings states, I cleaned out my parents' house that had a lot of mold in it. Since then, I can't smell very well. Could this be what caused it?
That's a question we get a lot about mold, especially black mold. If somebody sees anything really dark colored, then a lot of times they at least associate it with something bad in their health history. The reality of whether the mold is causative is a lot harder to prove. And if you truly have an allergy, if you could actually test the allergy for that specific mold, if you knew which one it was, that'd be a little more convincing. But it definitely plays a role, and it can certainly cause you to have some irritants in the airway, some more difficulty with runny nose and such. But there are some treatments that you can look into, but it's hard to prove that it's the mold.
It's been overdone. I think the allergists, my allergist friends will say, it's been overdone.
Yeah, usually if you're away from the exposure, it should get better, most of the time.
A 92-year-old woman from Arlington struggles with mucus and coughing each morning. She has visited her doctor about this, but has not found a solution. Any suggestions? 92, a lot of mucus, coughs in the morning.
Again, we have that issue with the regulation of the mucus formation in our nose. As we get older, tend to make more. We also tend to make drier, thicker mucus when we're on medications, a lot of them for high blood pressure or antidepressants or
diuretics.
Diuretics for sure. And then just in general, when you're sleeping all night long, and if you're a mouth breather, you tend to get a lot thicker mucus in the morning than if you're a nasal breather. So that can contribute to it as well. So trying to amplify the humidity and get rid of things that are dehydrating, like coffee, and frequently coffee and alcohol make a very big difference in what kind of sensation you have about mucus in the back of
a
your
little
throat.
steroid nasal spray.
That's always a good start. And saline rinses, and the two that are over the counter that are right now are mainly Flonase and Nasacort.
Nasacort, that's what it was. Okay. Caller from Rapid City says, I flew 3 years ago and my ear feels like it still needs to pop from the right. What causes this?
Well, it could be as simple as eustachian tube dysfunction. The tube that's supposed to allow you to pop your ear is not opening and you do have a pressure problem. It's amazing how many people who feel the sensation of pressure problems actually don't have a eustachian tube problem. They have a hearing problem, or some of the surrounding structures, especially musculoskeletal, like the TMJ or the neck, can contribute to that as well.
Okay, 4 minutes, 6 questions.
All right, buckle down.
A caller from Brookings states that her 18-year-old just got cochlear implants. Can you explain the impact of going from hearing aids to cochlear implants? Quick explanation of...
Cochlear implants are basically, they're going to go surgically implanted into the inner ear, so they bypass the eardrum in the hearing aid, or the hearing bones, and they directly stimulate the nerves. So those are that's the one surgery that somebody who's completely deaf may have complete restoration of hearing. People describe the quality as being different, and certainly things like music is not nearly as full, but it can bring you from being totally deaf to having almost normal hearing.
Almost normal hearing. Wow.
In some patients. And the younger you put them in, the better if you're born deaf. But some of these, I'm assuming probably in an 18-year-old, they've been progressively losing their hearing. And
with a congenital kind of
and finally
genetic.
got bad enough that they did it.
Can poor quality hearing aids exacerbate or make hearing loss from increased sound volume? I mean, you've turned up the volume, now you've got all this noise exposure. Can that be the problem?
That's a good question a lot of people ask, and it's unlike, if you're wearing earphones, earbuds or something, and you have that turned up way too loud.
Like all of our teenagers.
Exactly, where you're actually getting noise exposure. In a hearing aid situation, if it's been appropriately adjusted by a professional, it should not cause more hearing loss. A lot of people think it does because generally hearing loss is progressive, and so they blame it. But it's better to use it than not.
I recently had inflammation in my TMJ, and my jaw clicks and locks and hurts, and my ears hurt. Should I go to an ENT doctor or a dentist? And recently put on prednisone and antibiotics for the inflammation. I'm wondering what else to do.
Frequently, a TMJ problem is like an arthritis in other areas. It's an overuse injury, and there's things that can contribute to it if you have kind of an asymmetric bite, or if you have, if you're chewing, if you like to chew gum, if you're eating things that are hard and crunchy a lot. That's going to make it worse. If you're somebody who grinds your teeth at night or clenches your jaw a lot, that makes it worse. So frequently, bite splints can be helpful at night to keep the jaw from completely closing and putting all that stress on the joint. Anti-inflammatories like higher dose ibuprofen or Aleve, and using it every day, regardless of whether it hurts or not, for several weeks to help calm the inflammation down. Heating pads, massage. There's a big muscle that goes from the zygomatic arch here down to the jaw, and that massaging that muscle can oftentimes help relieve that. Also, it can sometimes be in the temporalis up on the side of the head as well. So those things all can be helpful, but
ENT versus dentist, kind of hard to know which.
It depends. Yeah, it is hard to know. It depends on what's contributing to it. And oftentimes oral surgeons, if it gets extreme enough to have the surgery or injections.
A 60-year-old sister wears a stem with her hearing aids. Can you explain what the stem is and how it works?
The stem with the hearing aid.
I don't know what it is.
I'm
Maybe
not quite
that's
sure.
the thing that helps you get it in and out.
I guess I'm not sure what they're referring to there.
We don't know the answer. That happens every once in a while.
I'm willing to say I don't know.
I seem to have phlegm a lot, and when I go to the dentist, he has to set me up about every 5 minutes so I can't breathe. What do I do? What kind of doctor do I go to? Phlegm that can't lay down.
Frequently that is more of a dry mouth situation, because you're supposed to be making mucus in your head all day long, every day, all night. And if it's the right consistency, it goes down okay. But if it's getting too dried out and thick, or if it's getting too profuse, there's multiple different things that can lead to it. So you probably need to kind of get it evaluated.
Wow. Go in, get it seen, ENT.
Yeah, there you go.
An 89-year-old is concerned about a gravelly voice. Her father had throat cancer.
89?
Yeah.
As we get older, our vocal cords atrophy, very much like other muscle tone does as we get older, and that can lead to irregular closure, and they can have more of a raspy, breathy voice and different pitch. But if you have a history of tobacco use, alcohol use, it's never wrong to get it looked at.
Have you take a peek? Last question, thoughts of non-invasive surgery for acoustic neuroma? That's a brain tumor.
They're probably talking about the radiation, IMRT, the gamma knife. Basically, it's focused radiation to just radiate the tumor and not radiate the rest of the tissues.
And it may well be a good answer.
Well, it can cause cystic degeneration, so sometimes it gets bigger. It can cause cancer, but it can be very effective. But a lot of acoustic neuromas now are being observed to see if they grow, because frequently they don't grow very fast.
They
you can just watch them if they're small enough.
Okay. And now for the winner of tonight's Prairie Doc quiz question, true or false. 1 in every 3 people over the age of 65, a total of 165 million people worldwide lives with hearing loss. True or false?
And say probably even more.
According to the World Health Organization, that's true. It was Bill Johnson from Stratford who answered the question correctly. Thank you, Bill, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Have you heard? The Prairie Doc has a radio show. Listen to your local radio station for Prairie Doc Conversations. This program features physicians and other health professionals discussing various medical topics important to you and your family. Ask your local radio station if they broadcast Prairie Doc Conversations.
Thank you for listening. Until next time, stay healthy out there, people. I came down with an unrelenting sore throat about 15 to 20 years ago. For years, I have tried to be discreet in prescribing antibiotics in most of my patients for fear of causing resistance in bacteria to the antibiotics. I did for me what I did for most of my patients, which was to avoid antibiotics and the doctor. However, after a week, the sore throat was getting worse. It was starting to keep me from opening my mouth normally, and I was running a fever. I called my friend, an ears, nose, and throat doctor who practiced at our local clinic with me. He squeezed me into his schedule and took a look at my throat. I noted his eyes got a little wide, and then he got up and left the room, returning with a large syringe attached to a big bore needle, kind of hidden behind. It was so quick I didn't have time to resist, and he placed that huge needle into my throat and stabbed the left tonsil and came back with a syringe full of brown liquid. He smiled and said, "Oh, you have a peritonsillar abscess." I had pain localized to the left side of my throat, which made worse with swallowing and which was suspicious for peritonsillar abscess. Other symptoms that could have indicated such a diagnosis included swollen tonsil or tonsils, uvular deviation from the abscess, a mouth that doesn't open fully, purulence of one or both tonsils, drooling, swollen neck lymph nodes, and finally a muffled voice. Usually there are two organisms growing, which makes this condition a double threat. If the infection is allowed to spread, the invasion of many layers of neck tissue can occur, which leads to a progressive extension of the infection into deep tissue and possibly a dismal death. The infection can also spread to the other tonsil, which, when swollen and pushed up against the opposite swollen tonsil, can block airflow and cause death from suffocation. My doctor immediately sent me down to an infusion room and started the daily IV dose of an antibiotic that would be repeated daily for a week. This was not the first time or the last that antibiotics saved my life. Following this experience, I looked much more carefully at every patient with a sore throat, and although I was still careful about overprescribing antibiotics, I prescribed antibiotics more often for swollen and ugly tonsils after that. A big thank you to our guest Jonathan for volunteering to come to our studio tonight. The flu is now categorized as widespread in South Dakota. Nationally, the Center for Disease Control estimates that so far this season there have been at least 13 million flu illnesses, 120,000 hospitalizations, 6,600 deaths from flu. Get your flu shot if you haven't yet, and take care of yourself and your family and friends around you. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people. Thank you for doing this.
Few things are as scary as not being able to breathe properly. We need oxygen to live, a lot of it. Problems breathing. Next time, On Call with the Prairie Doc.
All of us want our family, neighbors, and friends to have the ability to make appropriate decisions about their health care. To do so, they need access to information from reliable sources like Dr. Holm and his guest physicians. Hello, I'm Stephanie Herseth-Sandlin, and I serve on the volunteer board of directors of the Healing Words Foundation, a 501c3 organization established to support the work of the Prairie Docs. With your charitable donation, you can help the foundation continue to offer free and easy access to the entire library of Prairie Doc health education programs. This mission is so very important to rural communities and residents in particular across South Dakota and neighboring states. Please consider a personal or corporate gift. Just go to prairiedoc.org to find more information on how you can help. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And with the ongoing support of these individuals and institutions,
South Dakota Foundation for Medical Care,
Brookings Health System,
Ophthalmology Limited,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
American Academy of Family Physicians Foundation and the South Dakota Academy of Family Physicians.
Black Hills Medical Society.
Aberdeen District Medical Society.
Madison Brookings District Medical Society.
Sioux Falls District Medical Society.
Yankton District Medical Society.
Dakota Bank.
Orthopedic Institute.
Physicians Care Sanford Clinic Community Service Committee.
Aberdeen Asthma and Allergy.
And Swiftel Communications.